My name is Dr. Julius Gardin, and I'm professor of medicine, and I direct the cardiology division at Rutgers, New Jersey Medical School. And I've just had the pleasure of presenting a talk at the International Academy of Cardiology annual scientific sessions in Boston in 2018. And the title of my talk was Novel Ultrasound Imaging Strategies for Ischemia. I was involved as the vice chair of the Stable Ischemic Heart Disease Guidelines published by the American Heart Association and the American College of Cardiology and other organizations in 2012. And at that time, for someone with stable ischemic heart disease who could exercise, different options included the treadmill stress test, or with or without imaging with ultrasound or myocardial perfusion imaging, and then CT coronary angiography was becoming more and more validated, and also cardiac MRI. And over the last 6 years, I've been interested in a number of different technologies involving ultrasound, and that was the topic of my talk, really to talk briefly about 4 different strategies. One was targeted molecular imaging using microbubbles in order to image myocardial ischemia, called ischemic memory imaging. That was the first thing. And different groups, such as Lindner and colleagues, have been able to show that you can image in dog models ischemia that occurred not just now, but a number of hours back. They really did it using ischemia reperfusion imaging, but the idea would be that this might be useful in a patient who comes in with chest pain, whose EKG does not show an infarct or actually signs of ischemia, and whose troponin may not be abnormal, but they may have had an ischemic episode perhaps yesterday. So again, this is just an evolving technology, but there is the proof of concept using actually commercially available microbubbles and ultrasound to deliver these microbubbles to areas of ischemia. And it's done using destruction of microbubbles by increasing the mechanical index of the ultrasound, and then the microbubbles that are still left and can be imaged are those that have been bound to the area of ischemia. Another area that I think is very interesting is using ultrasound not only for imaging but therapeutically in a technique called Sono Thrombolysis. And there have been studies now that show that if you increase, again, the mechanical index of the ultrasound, you can actually help in thrombus dissolution. And this has been shown in a nice study by Matthias and Associates that recanalization of the artery using ultrasound before and after a PCI is seemingly effective in a study of 70 patients. It seemed to be most effective in the left anterior descending artery, but also in other arteries, and I believe this might have a lot of potential as well. Another technique that's been evolving for years, but I think is getting better and better in terms of documentation, is using dobutamine stress echocardiography along with microbubbles to show perfusion of the LV in addition to wall motion. And Tom Porter and his group have done an excellent job of showing how this can increase our detection of those who are going to have cardiovascular events in the ensuing 2 to 3 years. I believe that this technique has been around for a while. In fact, I referenced it in my Edler lecture 20 years ago for the American Society of Echo. But again, the proof of concept has been shown more and more in clinical studies. And the final technique that I discussed briefly was something that Victor Moravi and associates have been working on, and that is something they call fusion imaging, and that is to use CT, coronary angiography, and stress perfusion imaging using regadenoson and CT perfusion imaging, and comparing it to 3D echo strain. Now, strain is deformation imaging of segments of the myocardium, and they used the CT FFR, fractional flow reserve, as a gold standard for a significant narrowing. And they were able to show in initially a small clinical study that resting 3D echo, which doesn't require radiation, was modestly sensitive for detecting these lesions, sensitivity in 0.61 compared to the CT stress perfusion imaging, about 0.71. The specificities were pretty similar, about 0.66. And again, although both of these techniques need additional work, and there is some promise in this, the 3D echo technique has the advantage of not requiring exercise or radiation imaging. So I think the field is evolving. There's some exciting things going on, and we need to stay tuned to see when some of these may make it into guidelines for clinical practice.